Joyce, there was a question that Eric Geyer had posted, which I think, wow, I think a lot of people, everybody except me could answer. How can we distinguish the hypothetical anatomic predisposition of ODD, like a narrow scleral opening? How can you distinguish that from Mendelian conditions with molecular connections? This is basically, you know, an anatomy versus genes and anatomy and structure versus genes. Maybe we can go around.
Vinu, you're muted.
Oh, did you hear the question?
Yes, yes.
Okay.
You just cut off at the very end.
Oh, I said maybe we can go around and somebody could address that question, anatomy versus genes.
One of the questions is, do we know of particular disorders that have a smaller scleral canal and are not, I guess, per se genetic, but more of a deformation disorder? The ones I'm thinking of are our craniofacial kids or our non-syndromic craniosynostosis kids that have very anomalous appearing optic nerves. And prior to the ability to look with OCT, I don't know if anybody's looked to see if the scleral canals there are different. You could then pose that group with a sort of a deformation or a malformation of the scleral canal to those with a genetic syndrome. One of the questions I would pose. Does anybody know of any people who have looked at disorders that have a scleral canal deformation?
Well, Shannon, I think you're getting at kind of an interesting question too, which is anatomy is to a certain extent genetic. So can we truly separate those things?
Mm-hmm.
Well, the way I look at it is, I think the optic nerve head, no matter how large or small it is just a very, very small compartment. And so I think we should segregate the association between sort of developmental issues versus secondary sort of, acquired issues and growth and migration and calcification of the drusen as a result of just being in that confined space and under stress.
Which goes back to the question that Eric had, which is whether or not it's just, are these really genetic conditions and that there's some genetic basis for either the metabolic dyscrasia, or is it truly just that these genetic conditions have a smaller canal that then put them at risk for Drusen?
I find it interesting that the smaller canals are more strongly associated in pediatric Drusen, whereas in adults it's kind of mixed. And you almost get the sense it's kind of like a remodeling, no different from a pituitary tumor remodeling the cellar, that as the Druzens grow, that the optic nerve area can expand a little bit. And that's why in adults that, we don't see this strong association between small canal size and this size versus kids.
Exactly. Can I just comment on that? I perfectly agree with you. And some of the first studies actually by Brad Katz's group actually showed a larger scleral canal in Drusen patients. And this might actually be the case in the adult population of Drusen patients. If you have large enough Drusen, there's simply not enough space for them, so they need to push out the scleral canal. And that's definitely our impression, although we haven't really made the large study yet, but it's definitely our impression that the Drusen, as they enlarge, they expand the scleral canal. So the difference might be only there in the pediatric Drusen population.
It's my understanding, Stefan, that from your guys' most recent study, it goes down to age 11, 12, which is the age group that you guys focused on to look at the incidence. But to my knowledge, and from looking through the literature prior to this symposium, I was not able to find anything of documentation of what normal scleral canal should be prior to the age 11, which was your study. Your study at age 11 had a similar scleral canal opening to the adult size. So something happens before that. And the question I'll pose in my talk later on around 1 o'clock is whether or not we actually can feasibly measure these children with OCT.
Well, we actually had a smaller scleral canal in the Drusen patients and in the non-Drusen kids.
Mm-hmm.
So you might be right with the comparison to the adult population, but compared to the non-Drusen kids, it was significantly smaller scleral canal.
Right, I guess I was meaning, I took from your study that you're the only group that actually looked at a normal population of kids. So you have a normative data set of kids. I think it's like 18 or, no, you did 140 because you were 10 times the group of the Druzen population.
Exactly.
So you at least have a normative data that's out there of what normal kids at age 11 look like. But I don't have anything before that unless people can feel free.
No, I agree, yeah.
There's a paper that I can't remember the authors. It was an ophthalmology paper a few years ago where they looked at normals and they found that something like almost 10% of the normal eyes actually have findings like the hyper intense lines. I don't know if people have noticed something quite like that. I have not personally looked at the controls. I'm just wondering, now that the imaging is getting better and better, whether really everyone is kind of primed to develop abnormal axons as part of just the very high metabolic activity in this area, in that we're all kind of primed for Drusen formation, and then some people actually crosses a threshold, and then others have sort of continued growth and development of vision loss over time.
Yes, that's a very good point, Joyce, and we definitely have to look more into the prelaminar hyperreflective lines. Are they definitely, for sure, always ODD precursors, or are some people just continuously having these lines and never develop Drusen? We don't know yet, but what we do know from our follow-up study of the 11-year-old kids, well, 12-year-old kids until they were 17, that those that developed Drusen at 17 years old, all of them had hyperreflective lines at the age of 12. That doesn't mean that they are necessarily precursors, but it points in that direction. But I'm also familiar with the other study where you mentioned where there was a very, very large prevalence in normals with the hyperreflective lines. And that might also be due to some technical OCT issues. It's also important how you define those lines exactly. Are they just very, very tiny dots of hyperreflectivity, or how long does a line need to be? And of course, there's also the laminar cribrosa, and which can confound also, and sometimes look like a hyperreflective line. Actually, it's a laminar cribrosa.
Can I ask a question of Stefan? Oh, sorry, Joyce, go ahead.
Oh, I was just going to say, I just found the paper. It's by Mark Gassibi in Ophthalmology 2016.
Yeah, there was 14%, right? Yeah.
So I was going to ask, getting back to that question of the genetic influence on the size of the scleral canal versus the predisposition to develop Drusen. In the studies, your Copenhagen study, when you looked at people who were divergent or disparate in the size or the amount of Drusen or the presence of Drusen, were there equivalent differences between the size of the scleral canal? Because the genetic influence should be the same. And if there were a difference that's dependent on scleral canal size, that would point to the effects of the scleral canal as a result of causing the drusen as opposed to as a result of the genetic influence.
Yeah, we did not look specifically into that. It's a very good point. Yeah. We should be able to go back and look at the data. Yeah. Good point.
So Len, I thought maybe you could comment on your theory about venous stasis, you know, as a trigger for Nion. And I was curious what you think about that in the setting of Drusen plus minus Nion.
Well, first of all, you know, my ears were burning every time, Joyce, you mentioned compartment syndromes, since, you know, that went back to a study we did a long time ago. And I think that NION does develop as a result of a compartment syndrome. I think that's, you know, seems to be fairly consistent with what we observe and what we did pathologically in the clinical status. And I think the question is, and I think this is true for Drusen, it's true for venous insufficiency, and for anything else that essentially causes the this very small intrascleral area to become plugged up with stuff, is that you can develop ischemia. And if it's too tight, a small scleral canal, Drusen, whatever, you can develop a kind of a progressive cycle of ischemia lead to infarction. So I think these are all consistent. These are all different ways of getting the same thing. And, you know, it's all consistent. To me, the question, and I think it was Heather and I discussed this very briefly offline as well during the symposium, is whether papilledema itself, I mean, assume that the drusen are the result of an inappropriate response to axonal transport disruption, has been suggested by several people and by the literature as well. Then you would expect that having papilledema would put one at increased risk for those who have the genetic or other predisposition to develop drusen, to have higher drusen. And there was an article that came out in Neuro-Ophthalmology a few years ago, which did find a higher incidence in people with idiopathic intracranial hypertension of developing drusen. Of course, you don't know which came first. You know, was that the reason they're more likely to get the IIH was because of the drusen, although clinically we don't really see a lot of IIH with drusen. But for sure, I forgot the percentage increase, but a remarkably higher number of people who had drusen after the IH, but I don't think it was a longitudinal study. And that would be one way to also to get at this idea of which came first, you know, which is really responsible. Is it the scleral canal causing the drusen, or is it that the drusen in people who have a tight scleral canal develop something else are more likely to develop the calcifications?
Yeah, that's a really
Can I comment?
interesting. Go ahead, Stefan.
Okay, sorry. I think you're touching a very delicate matter here, and the question whether you can develop post-papilledema optic disc drusen. Personally, I don't believe that one, but that's a large discussion. But I think the study that you're referring to, where they did OCT, and actually a very large proportion, at least what they show in the paper, which they say are drusen, those are actually the forms. And we know that the forms, they are present in almost all patients with a true papilledema. So these are not drusen, it's early days OCT, and they showed a prevalence of 19% of, apparently 19% of ODD in IIH patients. And I believe they just actually diagnosed the forms as drusen. We have been looking at our IIH patients also, and we haven't seen any true, like the way we like to define drusen on OCT, we haven't seen any of them in developing in IIH patients. Of course, you can have IIH with drusen, but my impression is that the prevalence of optic disc drusen in IIH patients is the same as the prevalence in the normal population.
I think you need it. Well, it's a good question because you need a lot of people. Let's say that you have to have the genetic substrate of something that increases the likelihood of having the drusen. You would have to, you know, let's say it goes from the population prevalence to, you know, the, let's say, familial prevalence, or the, you know, whatever the genetic numbers would be. I think what, you know, we'd have to cooperate, but you have to take probably hundreds of people and to maybe to 100 people to pick up even one case higher than you'd expect. It'd be very hard to study it.
It is, yeah, definitely. I agree.
Yeah,
I'm just saying that the data that are out there, it's not convincing because they don't show Drusen.
I think you're talking about the paper. It's a 25-year longitudinal study by Dr. Birnbaum.
Yes.
Yeah.
It was in
Yeah, that's
JNO
it.
in 2016.
Yeah,
In that
also,
paper, I just pulled it up. It says it's 19% of the patients who had papilledema also had Drusen, but they don't know if they had Drusen before, but they know after that they had Drusen. But as Stefan's saying that possibly that was
That's not Drusen.
how they diagnose Drusen is not to today's standards.
right. It's also using it's a single person's clinic, and a lot of it was subjective, and they were diagnosed in different ways. But I'd like to sort of ask the other question: can papilledema cause Drusen, but could Drusen, by pressing on the axons, cause papilledema? And how do we differentiate that kind of compressive axoplasmic stasis from ischemic induced axoplasmic stasis, which is more of an NAION type of situation?
Yes, that's a very good question.
Well, it clearly contributes to the optic dysedema, whether that's at all related to intracranial pressure. I think, we wouldn't know unless we measure it.
Oh, I'm not proposing intracranial pressure. I'm just proposing that the Drusen, if you've got a tube that's a ganglion cell, and in papilledema, you've got intracranial pressure squeezing it, but if you've got a big rock sitting next to it, that itself could cause some compression and maybe axoplasmic stasis.
Yes, that's
Absolutely.
intuitively, that makes very good sense, that if you are a Drusen patient and you develop papilledema for whatever cause, intuitively you would expect a worse visual outcome afterwards.
But Heather, you're asking if the Drusen itself would cause edema independent of ischemia. Is that what you're
Correct.
asking?
So I think I'm using papilledema too much. So in the absence of high ICP, if a Drusen grows and exerts compressive force on the adjacent ganglion cell axons, could that cause axoplasmic stasis purely from force, not with any ischemic cause?
Sounds like it would.
Can I come out with just one short comment? We did look at our Drusen histology patients. We, as I mentioned earlier on this morning, we had 31 histology specimens with optic Drusen patients, and in some of them, I don't exactly recall the precise number, but in some of them there were clear evidence of disc edema as well as axonal, intra-axonal stasis, like you see in the optic disc edema histology specimens. So I think you got a good point there. Yeah.
We're actually doing some studies right now at Stanford to test this idea. So far, we've only done it ex vivo by injecting calcium phosphate containing nanoparticles into rabbit or pig eyes. Just to look to see, the whole idea about compartment syndrome and whether we could induce Drusen formation. It would be interesting to, hopefully report some of this next year.
One of our attendees has a question about ocular conditions that have FOMs other than Drusen. Stefan, I know you have published on this.
Yes, so we've seen it in all conditions with the crowded optics. Well, we can distinguish three types in a way. You can see forms associated with optic disc Drusen, and you can see forms associated with disc edema of any cause. That could be an AION, that could be a CRVO, that could be a papillitis, for example. And then the third type is forms associated with a tilted disc. So if you have this oblique insertion of the optic nerve, it also gives it this kinking or herniation of the retinal nerve fibers that we believe constitute the anatomic equivalent to the forms. So it's it's an OCT sign of a crowded optic disc.
Right, not Drusen.
Yeah.
Having this,
Sorry, do you
having
think
this,
that okay.
go ahead, Shannon.
Do you think that OCTA would be helpful for this question of whether or not there's this continuum of exoplasmic flow stopping that then causes papilledema, or that causes edema? And then I think Dr. Moss did a really nice job in her presentation, sort of showing this continuum of what happens when the osmoplasmic forces stop, and then there's swelling posterior to or distal to that. And then there's loss of vascular supply at that point. And it seems as though we know, at least in kids, that pseudotumor kids, their vision comes back, and they oftentimes don't have a vision loss. Adults with NION, when they actually have the vascular impact, have significant vision loss that doesn't come back. And there's that nice continuum where, you know, when does the final break happen, when the vascular supply or the energy supply outstrips the vascular supply at that point? Would OCTA be helpful in this particular scenario of understanding when the vision actually is irreversible?
I'm going to talk about that a little bit at 1 o'clock. So the answer is yes, but we could only do so much with OCTA. And so I think, I noticed Randy Carden in the audience. I think we need a combination of a vascular study that's relatively non-invasive, plus looking at oxygenation.
Mm-hmm.
I was just going to ask, since we have this august group assembled, to what degree any data is being developed around a non-compression hypothesis. And I'll put that in sort of two contexts. One is, for 100 years, we were under the impression that a glial scar after points of injury to the central nervous system, meaning astrocyte proliferation, et cetera, was a physical barrier. That's how it was actually envisioned by the early anatomists. And then it turned out to really not be a physical barrier, or maybe whatsoever. It turned out to really be a biochemical barrier of signaling molecules coming from reactive astrocytes to central nervous system neurons. Recently, I've been reading a few papers about another optic neuropathy from optic gliomas. And there again, which was, you know, something that I think was for a long time envisioned to be a compressive effect of glioma tumors compressing axons, in the more chronic setting appears, at least from the animal models, to be really derivative much more from signaling between astrocytes and microglia, for example, that are in the vicinity of the tumor, and that signaling is actually perhaps more directly or proximately responsible for retinal ganglion cell dysfunction and then death. And so I wonder whether how much energy, attention, thinking, modeling, et cetera, do people have thoughts about whether it's, especially in a case where it's chronic appearance or growth of the drusen compared to the acuteness of that may happen in the beginning of papilledema or certainly NION, you know, could much more of the story or a significant part of that story actually be around signaling processes, neuron glial signaling or otherwise, neuron vascular signaling, drusen vascular signaling, that really have little to do with the sort of otherwise obvious element of guessing that it might be compression from the physical, you know, rocks in the nerve head. So I'll mute and see if we engender any conversation around that.
I think the role of glia is definitely important. And based on our animal model of NION, the very impressive reactivity and markers of metabolic stress in the glial cells at the optic nerve head, we definitely wonder about that being a mechanism for NION. I actually went back to the literature for optic disc drusen to try to see what the description for glia at the optic nerve head has been. Granted, there's not a lot of these, old autopsy studies, but I keep coming across with the sentence like, the glia is normal. And so I think there's definitely, with the modern tools, better ways of studying glia than just H&E stain. And we're hoping to be able to do that in the future.
Can I comment also? I think it's very good also just not to focus too much on the compression theory. Of course, the compression does have an influence, but also to look more at the calcium signaling problem, because as far as I'm concerned, this is the only condition where you have calcium accumulation in the optic nerve head, well, in the optic nerve as such. You can have, of course, calcium anywhere else in the eye, actually. But there are these connections with diseases where you have calcium accumulation in other places in the body. We mentioned PXE early on with a high prevalence. And well, maybe this is, at least to some extent, a calcium disorder in a way, optic dysdrusen. So I agree with Jeff that it's important not to stare blindly at the compression theory of being the sole responsible, and looking much more into the calcium metabolism and calcium signaling pathways. Doing some studies of calcium metabolism in ODD patients.
Can I follow up on that? Because that's a fascinating thought. What makes the optic nerve head then special? Let's say the problem is some problem with dysregulation of axonal calcium concentrations and leading to some kind of a event. There aren't that many places where the optic nerve gets constricted besides the optic nerve head in a tight scleral canal, but there is one other, which is in the optic canal as it enters the skull. And it's very possible nobody's ever looked, just because you need really high resolution, preferably CT, and there's, you're surrounded by a big bony canal to begin with. But I wonder if it's worth doing some high resolution CTs or dual beam, dual X-ray voltages to really start to look at that. And you may find that it's also there.
I think the compression of the myelinated portion of the optic nerve is likely different from compression in the unmyelinated portion. There are some spontaneous animal models of optic nerve compression at the canal, as well as induced animal models. All the papers I've read talked about the myelin aspect, the oligodendrocyte. There's at least, maybe nobody's looking, but no one's described something that looked like optic dysdrusen, which is really only at the prelaminar area.
You mean in an animal or a person? Because
sorry, animal, animal study.
But I mean, I think you'd have to have the animal where it also has that constriction. I'm not sure even what, I'm thinking about when we do a dissection from a mouse or a rat, and it doesn't seem particularly tight. Well, in some people with canals, especially when the nerve goes in, it starts to then also like spread as it kind of goes under that dural like loop. And it's very possible that, if somebody doesn't look, they won't see it.
Mm-hmm. I wanted to follow up on Stefan's point about calcium. I was reading papers about calcium and mitochondria, and I was actually impressed that I think this phenomenon may not be unique to the optic nerve head. It turns out a way for mitochondria under stress to express its changes is basically to be calcified. Calcium spikes in the mitochondria are described in other body parts as well. And there are conditions outside of the optic nerve head, including in muscles, for example, where there's no compression, where you get these gigantic aggregates of mitochondria that are calcified. So I think I wonder whether this just happens to be, like a very easy place where we could image optic disc drusen and we could see it clinically, but maybe it's actually more prevalent than we realize. And then while I was reading in anticipation for this meeting, I found a single paper in American Journal of Neuroradiology that described 3 cases of calcified olfactory, they call it olfactory nerve, basically olfactory bulb, and there's no pathological study from that condition. But I found it really striking of just how bright it is on the CT scan. It's very, very much like what you would expect optic disc drusen to look like on CT scan.
Wayne Farmer in the Q&A also had earlier picked up on this question, and especially as to whether the lack of myelin anterior to the lamina cribrosa may sort of penalize that area for susceptibility to forming the drusen. And in just the last couple of years, there's been now a couple of papers now demonstrating that there's, in retinal ganglion cells in rodent models, using rodent models of glaucoma, there's a very high level of mitophagy that's happening right in that optic nerve head. And even there's other element called transmitophagy, where retinal ganglion cell axons are actually normally extruding their diseased mitochondria, and astrocytes there can then participate in gulping up those mitochondria and helping degrade them locally. And so the premise that may be overwhelmed in the optic nerve head, where that transmitophagy may be occurring in sick or challenged retinal ganglion cells and their adjacent astrocytes, and that may be different from anywhere else along the nerve, or maybe limited to very specific areas in the CNS or throughout the body, frankly. I think that's a very interesting possibility for this disease, not just for glaucoma.
One interesting question, all these theories, and I'm a mechanical engineer by background, so I love simple explanations that stem from compression. But if are the drusen both the result of sick ganglion cells and then the cause of the visual dysfunction, or might they both perhaps be symptoms of the cause of the sick ganglion cell, meaning that if the ganglion cell is unhappy, it is both producing drusen, and that whatever the underlying unhappiness causes is the cause of the vision loss, not the drusen themselves.
Can I just comment on this? If that was the case, Heather, you would probably expect a lot of cases with secondary drusen, right? So you have so many diseases where you have sick retinal ganglion cells, and so you should be able to do some good studies where looking before and after and see if they develop drusen using up-to-date gold standard techniques for the drusen detection. It should be pretty simple to test this hypothesis.
I have an unrelated question, but one that one of our patient participants brought up as well. And this one is to Vinit on retinitis pigmentosa, associated drusen, and some of the other retinitis pigmentosas with pain and photophobia. The patient brought up pain with eye movements as well. And a lot of people with drusen do report pain. I think Dr. Barris brought up that a lot of kids present with headaches, and then that's how they get found that they have an abnormal looking disc. So I want to just before the end of this panel discussion, get Vinit to comment a little bit about pain with RP, but also anybody else that wants to comment about pain with eye movements that this participant brought up. And I think we should listen to our participants because they're the ones that have it too, what they have going on as well.
Yeah, thanks. And I wanted to say thank you to all the patients that are also attending what's probably been a very technical discussion. So I'll say briefly that photophobic pain in bright light or different lighting situations is fairly common in retinitis pigmentosa, and certain specific genes can be associated with light sensitivity. Thankfully, the patients that I see with genetic eye diseases almost never complain of pain with eye movement. And so that would be atypical for retinal degeneration. That's usually largely painless. So pain with eye movement, I would usually send to Joyce or Heather.
But what causes the pain and light sensitivity in RP? Is it just those genetic variants, or what do you think is the pain? Where's the pain coming from?
Yeah, so I don't have the exact answer to that. It's not a uveitis inflammatory, but there's certainly wavelengths of light that are uncomfortable, and probably some ciliary related discomfort as pupils open and close in bright light situations. And certainly not all patients with RP complain of this. The typical complaint would just be that moving from one light situation to the other takes a long time to adapt to. So, somebody else may have a thought or answer on that.
My understanding was there was the melanopsin pathway that was involved in this, and I think, Kathleen, you've done some work with the melanopsin pathway and contributing to pain.
Well, that's the blue light spectrum contributing to pain, but I've always been struck by how light sensitive some of these people with retinitis pigmentosa really are, and some of our patients with Drusen are light sensitive, and I don't know if that's out of the ordinary or not. I'm just bringing it up to this august group who've seen a lot of Drusen.
Seems like the pain is not directly correlated with the severity of vision loss. So I think there may be additional mechanisms that are unrelated to the vision loss itself. And I can't help but wonder, for sure, NION patients talk about this pressure, there's something going on. And I kind of wonder whether it's the patient's way of sensing the compartment syndrome. And that it builds up, over years and, decades, frankly, into a sort of hypersensitization.
There's also certainly some bias in that the patients who have their drusen recognized, as Shannon highlighted in her case presentation, often that happens because they have pain and therefore they get looked at a little more closely. But I don't think that's the whole story.
So we're a little bit over time now, but I wanted to just take like a couple of minutes if everyone is still okay, because we want to make a list of unmet needs. And so I thought, since we have such a great group, both as a panel and in the chat, if people could just sort of shout out what you feel like are the most important needs in optic disc Drusen research.
Oh, I'll start. Do the Drusen in other disorders, are they, as was mentioned before, pathologically, clinically, let's say molecularly the same as Drusen in the Drusen we're talking about mostly today?
I would go back to that question of whether the biological effects of Drusen on the cells around them, outside of any physical effects, getting a handle on studying those. I think that's a huge unmet need.
What are the clinical and epidemiological risk factors for not only developing Drusen, but developing vision loss due to Drusen?
I wonder whether the mechanism of vision loss, if there are shared mechanisms between optic disc Drusen and other optic neuropathies affecting the optic nerve head, like papilledema, glaucoma. And a second related question is, why don't they all get NION?
And I think the one we've been talking about a lot is the size of the scleral canal and what's going on with that. Does that have anything to do with it at all?
Can I just a brief comment? I know we're running out of time. A brief comment to your question, Joyce. We looked at the ODD iron patients in the retrospective study, just a little bit. We're going to look more at it in the prospective study that we're going to do. But what we found was very interesting, that many of the ODD iron patients, they only had a very, very tiny little ODD. So it's not that you have the ones that get the iron, those are the ones with the big drusen. Not necessarily. You can have a very, very small one, but it's just located in the right or wrong place. So, so to your question, why don't everybody gets it? It's probably something to do with the precise location probably next to the posterior ciliary arteries. I don't know, but probably. But in that way, it will also be interesting to get the multiplexed imaging where we both have the OCTA and the OCT on the same patients. So we're going to learn more about this in the prospective study.
My bias addition to the list is actually seeing how these develop in the young age group and how do they progress? Do they migrate? Is it the RNFL actually melting away? What is the progression of these and how do they multiply and how they go from varied to superficial? And looking at the scleral canal in this age group is important because we know that this is when things are developing, and it's the unmet need of us not knowing what's going on in that age group.
I would say that one of the very important things that is down the line what we just talked about, it's what is the risk phenotype of an optic Drusen optic nerve head. So because we know that you can have very large Drusen and not that much of a visual field effect, and you can stay like that for a very long time. We showed this prospective 56-year follow-up of patients with very little change in visual fields, although they had a very big Drusen. And so we really need to identify as early as possible who are the disc at risk Drusen patients for developing complications down the line. That would be one of our major goals.
Well, that's a perfect segue to the 1 o'clock hour, which is on human measurements and biomarkers. So I want to be respectful of the time and make sure people get a little bit of break. So we're going to resume at 12 o'clock for the patient stories. I hope that people will feel free to comment from the audience. Thank you so much for this.